participation, we have to say some words. Dr. Quan-Yang Duh is Professor and Chief of Endocrine Surgery at the University of California, San Francisco, and attending surgeon at the Veteran Medical Center in San Francisco. He specialized in surgery to treat tumors of thyroid, parathyroid, and adrenal glands. He obtained his BS from Yale University, MD from University of California, San Francisco. He trained in general surgery and endocrine surgery at University of California. He is past president of the American Association of Endocrine Surgeons and received the American Association of Endocrine Surgeons Oliver Kopp Meritorious Achievement Award in 2019. He was the American Association Thyroid Association Polestar Award Lecturer in 2017. He is also past president of the Pacific Coast Surgical Association and was first vice president of the American College of Surgeons for the period 2021-2022. He is the president-elect of the International Association of Endocrine Surgeons. He published more than 400 papers with an H index of more than 100 and co-edited 3 textbooks on endocrine surgery. He is on the editorial board of Thyroid, BJS, JAMA Surgery, Journal of Clinical Endocrinology and Metabolism, Journal of Endocrine Society, as a Journal of Surgery, and others. But let me say that above all, he is one of the masters of endocrine surgery. And for most of us, he is an unreachable model as a surgeon, as a teacher, and as a researcher. Dr. Quan-Yang Duh, thank you for being here with us.
Thank you very much. It's wonderful to be here among friends. And I have to tell you, this is the second time I've been to the European meeting. This is just incredible, the presentation that I just heard, for example, in the last session, and all the workshop that you do here. I'm just absolutely impressed with how wonderful this meeting is. So we'll go on with this, and as you all know, I can always talk forever, and I'm keeping you from your lunch, so we will try to make this as quick as I can. I have no disclosure financially, but I have to say I was very surprised when the organizers asked me to talk about this topic, because obviously I'm not a lawyer and not an ethicist, to know that probably all of us are experts in ethics, so I guess it's okay for me to talk about ethics. I have to tell you that I'm absolutely at the boundary of my ignorance. So, so let's go on with that. I'll give you some background, talk a little bit about FDA and the process, how new technology comes about, safety and efficacy, some standard of care, informed consent, and we will see. And I like to leave some time for discussion also, because this is a topic that obviously everybody in the room have something to say about. And we heard some good lecture yesterday about the history in this area. And Hippocrates is in the just south of here in Cos. And really, if you think about it, our medical ethic was going as far back as that. And the key thing that we know about Hippocrates, even though it's not in the actual oath that we take as a doctor, that it is well known that he tells us that the first do no harm to our patient. And that's probably, if you don't remember anything from this lecture, you want to remember that. That's really the major part of what ethic should be for our innovation. Do not do harm to our patient. Now, we are in the area of Pergamon, and if you, Cos is just south of here, and Pergamon is obviously just in the neighborhood. And Pergamon is where Galen came from, and Galen is probably the original endocrine surgeon. He described recurrent laryngeal nerve as a branch of the vagus nerve, and he actually even mentioned 2 incidents of voice losses after goiter surgery. So you can imagine that those problems such as voice was already existing 2,000 years ago. In fact, he used to do a trick. He would have squealing pigs, and he would cut the recurrent laryngeal nerve, and the pig would stop squealing. So it's one of these party tricks that he did in the Roman court. And these are probably the kind of instrument that Galen used in the old days, the surgical instruments like this. This is from a temple that in Egypt. If you fast forward about 1,000 years, and there was not a whole lot of advances in those days. To take care of a goiter, you actually use setons, just like what people would do now with anal fistula. You put setons, and then you tighten them, and the goiter falls off, and that's the treatment. Fast forward another 700 years, and now the modern era of thyroid surgery is, of course, we all recognize Coker as a founding person for the modern surgery. And you can see that he described basically the function of thyroid hormone, even though he did not know the existence of the thyroid hormone. He knew that if you do a total thyroidectomy, you end up with hypothyroid patients. Now, and this is in my operating room. I have these instruments that I use nowadays. You can see there's a Coker, there's Halstead, there's Mayo, there's Cryo, there's Leahy. And this is a very good paper, actually, that talk about the Magnificent Seven of modern thyroid surgery. And you know, when I think about this, these are the names that we use every day. Now, if you think about the advances in endocrine surgery, I mean, we heard a lot of it during this meeting. There are certain themes that come out. One is that modern endocrine surgery is multidisciplinary. We focus on evidence-based treatment and diagnosis. You can see that, for example, you're making guidelines and things. The treatments are becoming personalized. You just heard some talk about how we study the genetics and of diseases. And we focus more now on quality of life. You heard about a lot of these talk also, and we think about the right and wrong of what we do. And so I'm going to concentrate mainly on the innovation and the new technology. Now, innovation, they're actually in two ways. One part of innovation is how do we think about the disease conceptually. So we think about, for example, thyroid cancer, we think about molecular genetics, we do the same thing for aldosteronism, we do the same thing with pheochromocytoma. We now understand the hormonal basis for obesity, for example. But innovation also involves how we operate technology. Intraoperatively, we use different types of way to do hemostasis, for imaging, we do monitoring, we have rapid assays, and we have augmented reality. We do operations with endoscope, with robot, we do telesurgery now, and there's some non-surgical alternatives, such as thermal ablation for thyroid nodules, and we use new technology like AI for surgical decision making. And if you think about it, it's the interaction of both the technological advances, new devices, new technology, with the surgeons who apply these things. We use different techniques, different approaches for surgery. But these also are affected by the conceptual differences that we learn in surgical conditions and surgical diseases. And there's an idea that we all know called paradigm shift. Now, paradigm shift initially was really described for how we change how we think about things. But in surgery, paradigm shift is not related to just the ideas, just the science of what we do, but actually the technology of what we do. And for example, one of the major paradigm shifts that we have was endoscopic surgery. Another one is robotic surgery, okay? And then there will be more things like AIs. And if you think about the domain of innovation in terms of technology and surgical technique and concept, paradigm shift apply to all three of these domains. So let's think about innovation in surgery, in technique, in technology, in approaches. We usually think through it this way. Can it be done? Can it be done safely? Is it better than what we already have? And can it be actually worse than what's being done? And what are the alternatives? And then finally, should we do it? Who should be doing it? And who's going to be paying for it? And these are all very important issues when we think about innovation. And this is one of my favorite quote from one of my heroes, endocrine surgeon Blake Cady. Blake Cady is a surgical oncologist, and this is one of his favorite saying: biology is king, selection is queen, technical maneuvers are prince and princess. Occasionally, the prince and princess try to overthrow the powerful forces of the king and queens, and sometimes with temporary apparent victory, but usually to no long-term avail. So we need to be thinking that the new technology that we use are the prince and the princesses. The disease that we treat are the kings, and selection is the queen. Okay, so keep that in mind when we do this, thinking about technical maneuvers and new technology. Now, if you think about the ethical legal issues in surgical innovation, we need to be thinking about risk. So first, do no harm. So we need to be thinking about risk, because changes are, when you have something new, there's always some uncertainty, because you don't have time to know about what is the real risk, especially what is the long-term risk. Is it safe? Does it work? You need to think about conflict of interest. What's the motivations for us, for surgeons, to do new things? What's the motivation for patients that want to have new approaches done for them? We need to be thinking about informed consent. We need to think about who control new technology, who has the oversight, what are the liabilities, and also, as important, what about access? Only the rich people get new technology, but not the poor people. Only the rich countries get new technology, but not the poor countries. What are the barriers? Okay. What is fair? And what about privacy? We think about all the data that we have right now. And so in the ethical issue of innovation, we think about the tools that the surgeons use. We think about the surgeon ourselves, our interaction with the tools that we use, and our interaction with our patients. And all of these things have ethical and legal implications. So, if you think about the process of innovation in new surgical technology, like medical device, first, somebody has an idea. Oh, we can do this, maybe. Let's try it. But in my own lab, I always say ideas are cheap. Okay? We can come up with 200 ideas, 300 ideas. Just right now, we can come up with 1,000 ideas in this room. But then, somehow we need to implement these ideas, and we need to test them. If you have a new device in animal first, and you have to test it in human, you have to have institutional review board to take care of these. And in the United States, the devices are regulated by the FDA. And these are the alphabet soup for FDA. There's FDA, there's IDE, the 510K, the PMA, etc. So for a new device to be used in the United States, you need to have investigational device exemption. And there are several ways that one can do that. And here's one of the terminology that sometimes people get confused about: FDA approved versus FDA cleared. So the FDA decide that if something is high risk, then they need to have approval. If something is low risk, they can be cleared. So for example, initial robot would need to be approved, but then subsequent changes to it, or something new but not that new, and it's substantially similar, they can be cleared rather than approved. Now, the pre-marketing approval, so somebody makes something and you need to have that sold to the hospital, to the surgeons to do, you need to have pre-marketing approval. And it is very, very stringent. The FDA requires that these pre-marketing approval has a sufficient valid scientific evidence that provide reasonable assurance that the device is safe and effective for its intended use. Okay? Now, there's a process called the 510K. 510K is actually most of the devices that we use is approved or cleared by the FDA using 510K. 510K means that I have something, this new thing that I make, but it is safe and it's effective, and it's substantially equivalent to something called a predicate, meaning something else is there before. So if I make a new neural monitoring device, and I say this is very similar to the one that people are using before, then you can use something called the 510K. Okay? And this is probably what most of the devices that we do come through the 510K clearance. And I borrowed this slide from one of the manufacturers of devices. That basically, there are different classifications of risk to the patient. So if the risk is very low, then you don't even need an IDE. If the risk is moderate, then you may need to have an IDE, and usually that's a very standard approval. If you have IRB approval, you will be getting the IDE. And then the class 3 are the highest risk devices, and that you need to have a more significant investment in terms of getting FDA clearance. And you can see the timing that it takes for these devices to come to the market. And this is another slide that I borrow from them, that as surgeons, we tend to be involved much further down the road there when we're doing clinical trial and using it. But there's a whole thing of product development before that, animal testing, etc. So I'm going to tell you a cautionary tale. So my good friend, Woon-Young Chung, who's famous for developing the transaxillary robotic operations, and this is in the early 2010, and many Americans were very excited about doing transaxillary operation. But one of the things that you have to remember is if you use a robot, this is 3 laws of robot. Those of you who know about science fiction and know about Asimov. And the first rule of the robot is a robot may not harm a human being, okay? But the robot that we use, unfortunately, in the United States, doing transaxillary, did harm human beings. And between 2009 and 2011, there were 13 complaints and 5 medical device reporting related to thyroidectomy performed with the Da Vinci system. And then Intuitive, in 2011, basically sent out a letter telling the people that own the robot, it is no longer FDA cleared for thyroidectomy. And in fact, there was warning that got sent out from the FDA. And of course, that becomes a problem because now if the robot is not cleared, the lawyers got involved. And so there's numbers of lawsuits related to the robots. And then in the United States, at least, if you look at the number of robot thyroidectomy, came dramatically down. And it probably has not truly recovered. If you look at the thyroidectomy that's done in Asia, for example, and even in Europe, there are much more robot use of thyroidectomy in other countries than in the United States. So just that one thing made a difference. Now, of course, the current Intuitive robots are actually FDA cleared for this. So that's this a single port, and the Da Vinci 5 and Da Vinci Xi, these are all FDA approved and cleared. So I don't want to tell you that in the United States you cannot use it, because now you actually could. But having that one problem really slowed down everything. So the FDA regulates the surgeon's tools, but it does not regulate what you do, how you operate. So let me give you an example. If I'm doing a kidney transplant, and I do it all different ways, the FDA does not regulate that. But if I do an islet cell transplant, like we're doing some islet with parathyroid transplant, for example, that need to be FDA approved or FDA cleared, because the process of making the islet cell is considered, now that it's been processed, it's like a drug that you make. Whereas if you take a kidney and put in another person, that does not require FDA clearance. So it's very important to know that FDA is only involved in the tools, in the drugs part of this. So again, if we want to evaluate new operations and new tools, we need to be thinking about, can it be done? Is it safe? Do we have new complications? Do we have more of the old complications? What does it achieve? And should it be done? Now, when you think about some criteria for adapting new technologies, we tend to think about safety and effectiveness. And so I want to just put a concept in your head that's a little bit tricky to think through about effectiveness. So efficacy and effectiveness are actually two different concepts in outcome research. Efficacy means the ability of an invention or intervention to produce a desired beneficial effect in expert hands under ideal circumstances. So this is when things first start and somebody can do it very, very well, and we say that is efficacious, okay? Effectiveness, on the other hand, means that the ability of intervention to produce the desired beneficial effect in actual use. So for example, this would be, you look at Endocrine data, and there's lots of people doing this, and that will be effective versus efficacious. And so efficacy in control trials show that there's a treatment effect. It has internal validity, basically says that it can be done, and it can be done well. Effectiveness means that the treatment effect can work in the real world. It typically is if you do that, okay? So let me give you an example. Robotic transoral thyroidectomy is definitely efficacious because there's a number of people doing that. But one can think about, is it effective? Are there enough people doing it with the same effect? We don't know that yet. And for me, I would say transoral robotic surgery, it's efficacious. I'm not sure yet whether it's effective. On the other hand, as I have to change my slide, by the way, about autofluorescence yesterday, because I saw the data from Endocrine. And I would say now autofluorescence is effective for preventing at least immediate post-operative hypocalcemia, okay? So keep these different words in mind. And then there's another E called efficiency, which is even further down the road, that whether or not you can do it with less resources, etc. So when we accept advances in surgical technique and technology, these are the things that usually makes it work. Simple is always better than complex, okay? The changes that make things become simpler, it would tend to be accepted. We need to make sure that the results are reproducible, low variability, easily teachable. That's another thing that's incredibly important when we have new technique, new technology, and the complications should be known and predictable. So these are the things that the criteria when we judge new technology. Now, again, let's come back to the ethical legal issues of innovation in endocrine surgery, again, between the surgeon and the tools and the surgeon and the patient. So let's concentrate on the surgeon and the patient. Standard of care. Now, what is my professional responsibility to my patients, okay? And this is standard of care is related to the medical legal aspect of things. And in the United States, actually, this is a fairly recent paper. We have 50 states, and every state has its own law governs your interaction with your patient. So, for example, for informed consent. And there's a recent change. It has not come to the law yet, but the recent change in thinking about what is a legal standard for proper care for your patient. Historically, most of the medical legal things, it depends on customary practice, meaning that I'm in a community of 100 surgeons. What do people usually do? So if I do what other surgeons do in my community, then I fulfill my professional responsibility with my patients. But they are thinking about changing that to reasonable medical care. You say, well, that doesn't sound that different, but it is actually quite different. Okay? So if all the surgeons in my community do total thyroidectomy and central neck dissection for a 1 centimeter thyroid cancer, then I fulfill that community standard. But if my guideline says I should be doing a lobectomy for that, then I'm not fulfilling the reasonable medical care thing. So the evidence-based and practice guideline will be, not yet, but will be very important in at least the American landscape for thinking about medical legal issues. So this is proposed by the American Law Institute, and it says that if you adhere to appropriate guidelines, and then that's sufficient evidence to say that you have met the standard of care. So if I translate that for you, is that in the United States, very soon, it's going to be, if you have followed the guideline, you are protected from the lawsuit. Now, the other way around is not necessarily true. Like, if you're an expert and you did not follow the guideline, as we know, that probably most of us follow the guidelines maybe 90% of the time, and 10% of the time, for specific reasons for that particular patient, you're not doing things what the guidelines say. So they cannot sue you just because you didn't follow the guideline. But it's going to come to that they are not going to be able to sue you if you follow the guideline. So, and I don't know whether this concept will become also become a European idea. So, and in fact, this particular law institute also talk about that you need to answer your patient truthfully, including your own skill, your experience, any financial interest and circumstances. So even if you're not required by law to do that, they think this is very, very important, and in fact, it will be your informed consent related to your patients. So informed consent in the United States, at least, has a long history through 100 years ago, and Nuremberg Code and Declaration of Helsinki, and finally to the Bellman Report. Now, the Bellman Report is the ethical principle and guidelines for protection of human subject of research. And basically it has three main things: respect for the person, beneficence and justice. And these are the ethical principles. Beneficence and non-malfeasance are basically very, very similar. And it says that the patient has the right to receive information and to ask questions and to be told of all medically appropriate options, okay? And they can then make the well-considered decision. Again, the patient is the focus, okay? And it is beyond the golden rule. The golden rule says that you would want to do for other people what you would wish they would do for you. But surgeon-patient relationship is beyond just the golden rule. We actually have responsibility for our patients. And nowadays, we need to share the decision with the patient, and we need to respect the social and cultural differences that you and your patient may have. And the professionalism of surgeons, basically, it's based on your motivation in your decision making. Anytime you make a decision, and this is not just related to new technology, that you need to be thinking that what you're doing is for the benefit of the patient. The patient's interest always comes first, okay? And I want to give you some personal story. I can see the clock is running down, so I'll tell you some personal stories. This is the first time. So my first laparoscopic adrenalectomy happened to be my 100th laparoscopic operation in 1993. And we invited Michel Garnier to come to San Francisco because he published his paper the year before, and let's do it. 3 days before he was supposed to come, he did not. He decided that he canceled the operation. And Alan Sipperstein and I, that we had to talk to the patient, and we say, initially we had this, expert that was going to come to San Francisco, et cetera, et cetera. We have to explain the whole thing. And we explained to the patient that it was our first case. And of course, that first case took 7 hours. Now, I cannot imagine doing an adrenalectomy of 7 hours, and I don't know whether my informed consent included 7 hours of this. Let me tell you another story. So my first transaxillary operation, so I went to learn transaxillary from Suchar, and I work at the VA in the university. I went to my patient, and I say, sir, you have this nodule in the lobe that could be a cancer, and we're going to do a right lobectomy, and I'm going to do it through your armpit. He said, why would you want to do it through my armpit? I say, well, so you won't have a scar in the neck. Okay, so of course he started laughing. He's an old veteran, 60 years old, all kinds of scars and wrinkles, and he started laughing. He said, are you kidding me? No scar in the neck? Give me a better answer. I said, okay, this will be the first transaxillary operation done in the VA system. He said, will be number one? Yes, we will do it, okay? So patients have very different reason for wanting to do things, okay? Anyway, so patients' assessment of risk and benefit are not always objective. I mean, in the United States, the remote access surgery is not as popular as in Asia, for example, and there's difference in terms of how people value these things. And in the United States, people value something that's new. So if I say, I'm going to fix your hernia with a robot, they say, oh, wow, that's great, that's new, that must be improved, even though we don't know for sure that's an improvement, okay? And sometimes people do it because they want to help other people. Let's talk about conflict of interest. I know I'm running out of time, so real quick. The surgeon needs to disclose your conflict of interest with your patient. You need to be transparent, and you need to be aware that sometimes there will be subconscious conflict of interest. The device manufacturer should never be involved in the decision-making of your patient's decision. And keep in mind, the patient themselves can have conflict of interest, and we need to address these things. So, accountability. Now, the standard in the United States is you are the captain of the ship. So something happened, you are responsible for it. But there's beginning to have some change in thinking about it because we're using these new tools that the surgeon may not have a lot of control over, okay? You're using a robot, okay? You're using some AI stuff that has a black box. So how do you account for those things, okay? But keep in mind that if I drive a Tesla and I hit somebody, it's still my fault, okay? Because I am driving that car. But there may be some shared decision-making because the software goes wrong and you hit somebody, then the company is also in trouble. So the shared responsibility. Now, I'll skip through some of this about who pays for it. Okay, this is about how money gets into the system and paying for it, and this is really related to the conflict of interest. And I was thinking about that. So I was in Taiwan visiting my family, and I look around. This is the night market, and there's this big poster about radio frequency ablation for your thyroid. Like, this is in the middle of a night market. And only about a month ago, I got this email. And the email is, are you having thyroid surgery? Have you thought about doing it differently? How about doing it with radio frequency ablation? And then the end of this is, hey, maybe if you're a doctor and you do radio frequency ablation, contact us. We will market for you. Okay. Now, these are all have a lot of issues in terms of ethics and that. We heard about AI. This is all, AI mostly now is used in radiology. But there's a lot of issues when we use AI and machine learning thing in surgery. There's issue of informed consent, there's issue of inequity, data privacy especially is very important for AI, and accountability, etc. And so in the United States at least, AI software is regulated as if it is a medical device. Okay, so you need to remember that if you're making some AI things, that's actually considered like an AI, it's a medical device. Okay, so I'm coming to the end of this. I talk about domains of innovation in surgery. We talk about the ethical legal issues between the tools and how we use it and relationship with our patients. So I hope you enjoyed my lecture here. And unfortunately, that video is not playing, but that's the Waymo in San Francisco. So I take that all the time. Self-driving car, new technology. In fact, I was going to show you that driving that thing, you can see the Golden Gate Bridge, and that's how we do it. And pretty soon, we may have a self-driving robot that where you put it in the patient, and then they'll do the thing. So thank you very much.